Hello, everyone. We're about to get started. We're very excited to have Dr. Ann Fenton and Dr. David Sears here today to share some cases from the 360 clinic over at Parnassus. I'm going to introduce Dr. Ann Fenton first. She is an assistant professor and ID physician at the 360 Wellness Center, really passionate about comorbidities and resistance, and as well resident education. And her sign is Libra. Dr. David Sears is a professor of medicine, works predominantly at the 360 Clinic, site director for the ID Fellow Continuity Clinic, and his sign is Aries. We're very excited to have them. Actually, don't know who's going first. Okay, great.
All right. Good morning, everybody. Thank you so much for inviting me. Wonderful to be here. I'm excited to share this case with everybody. There are kind of two aliquots for this. So there's an appetizer and then there's a main course for this case. So this is the appetizer. And this case is from a couple of years ago, but actually this is, you all are seeing the world premiere of this case. This is the first time that I've presented it. And I think has a number of interesting kind of challenges and learning points and also will be a nice opportunity for me to survey the audience and what they do. So this is a 36-year-old man with a history of bipolar disorder, epilepsies, and allergic asthma. And he's referred to our clinic following a new diagnosis of HIV while being prescribed PrEP. So his risk factors, MSM, he has a long-term presumed HIV negative male partner. They're in an open relationship, and he estimates he has about 10 other partners a year. And he began PrEP with daily TDF-FTC about 5 years prior, and he was HIV negative at initiation. He describes these rare periods of adherence of taking maybe 5 to 7 doses a week, but most of the time he was not taking PrEP during the prior 5 years. And or he would take it a few times a month, and the dosing was really correlated with his housing and housing stability as opposed to perceived risk. And I would say there are wide confidence intervals around his PrEP dosing estimates, but he thinks that during the prior 5 years he took maybe 6 months of PrEP during that time. In his last PrEP use was 3 months prior. So he was really not regularly in care and was moving between clinics in California and Nevada, never had really set up reliable PrEP care or primary care during this time. And his renewals came from a whole bunch of different providers from what he told us and what we could find through the medical record. So he tested positive for HIV 10 days prior to coming into our clinic. Unfortunately, per his story and per everything that we could find in the chart, his last HIV test prior to this negative one was 4 years before. So he had has a very, very concerning history of not having regular testing while being prescribed and occasionally taking PrEP. I feel like we often get some of these concerning histories. This is hands down the most kind of concerning history in time since last negative HIV test that I had seen. So his social history, so he's unhoused. He and his partner have been staying with a friend for the last 3 months. So things had been a little bit more stable, which is how he got reestablished, or not reestablished, but established for the first time in UCSF primary care. Also was established in epilepsy clinic and had restarted medications. And then when he had established in UCSF primary care, that's when he was tested for HIV and found to be positive and referred to us. Prior to these last 3 months, he had been intermittently staying both in shelters and sleeping outside. And then from substances, he does use intermittent stimulants, meth, which is primarily inhaled. So the labs when we first saw him, so we did confirm he had a 4th gen antigen antibody, which was positive, and his HIV-1 antibody was positive as well. He had an RPR of 1 to 8. We did find that he was 1 to 256 4 years prior at the time of that last HIV negative test. And he had to have record at least of getting an injection of benzathine penicillin. He was Hep B surface antibody positive and surface antigen negative, Hep C negative. He had a GC chlamydia test in his urine only, which was negative. And then his Chem7, LFTs, quants, A1C, and lipids were all unremarkable. So audience poll. So I have a bunch of polls, really not true MCQs, but this, so I'd love to hear kind of what you're thinking at this stage after the appetizer. So this patient has been adherent to other medications during the last 2 months as he got reestablished for epilepsy and primary care. While his housing has been more stable, he is motivated to start HIV treatment today, but has this, very concerning history of no HIV testing for 4 years prior to his positive test, and then very intermittent oral PrEP use over a long period of time. So what would you start today? These are our options. Okay. All right. So we've got a couple folks. All right. So we have interesting distribution here and some more votes coming in. So yes, as I'm sure you're all aware, kind of, for most of our guidelines, oral PrEP failures, very low rates of acquired resistance at the time of testing positive. And so in general, we stick to our kind of first line regimens of 2 NRTIs and an INSTI. But this case, I think, is at least different given, the sort of higher risk, I would say, for the possibility of resistance. So we see some results for using a bictegravir into an NRTI regimen, TAF-FTC boosted darunavir, and then a darunavir, boosted darunavir and dolutegravir approach. So great. I think these are all things, at least at this stage, that I was considering. Nobody wants to do long-acting injectables, which I think is reasonable at this time. So at least, after the appetizer portion today, I think this case brings up obviously a few questions. Is how likely is NRTI resistance after oral PrEP failure, and are there risk factors of NRTI resistance among breakthrough infections that could help us estimate, maybe with greater likelihood, how likely this patient is to have NRTI resistance with greater precision? And then can we trust a genotype? We'll obviously get a genotype at this stage. After the patient has not been on any oral PrEP for the last 3 months. So I think there are a number of smaller studies that look at this. I did want to highlight this review from Lancet HIV from a few years ago, which was a meta-analysis of HIV infections among patients on PrEP in these major clinical trials. And looking at the incidence of tenofovir and 3TC or FTC mutations among those who acquired HIV after PrEP initiation. So a pretty big difference between those who seroconverted at the time of PrEP initiation, where among those patients, we saw high rates of resistance. About 46% of those patients had resistance. Most of those are in green. This is the pie chart on the left. So the green ones are intracytobine resistant, but some of them, 9% had both resistance mutations, and then 9% had tenofovir only mutations. Whereas the rate of NRTI resistance at HIV acquisition for people who acquired HIV later on, so we're not seroconverting at the time of initiation of PrEP, but acquired it later on, was much lower, so 10 times lower. So basically, those patients had a rate of 4.9% of acquiring resistance if they acquired HIV after starting PrEP, not because they were seroconverting at the time. So much lower rate, so 10 times lower. That said, I sort of think given this history of maybe 6 months of PrEP use over a period of 4 or 5 years and not knowing when he really seroconverted, I would suspect this patient might be a little bit more like the patients on the left who have rates of resistance around 50% or so, as opposed to the patients on the right, even though he would have fallen into that pie chart on the right. Fortunately, at least most of the resistance mutations, again here in green, are intracytobine or 3TC resistance mutations. But again, there is that risk of tenofovir mutations, and 18% of the patients who acquired HIV after starting PrEP did have a tenofovir mutation. So what about risk factors for NRTI resistance among these breakthrough infections? Could any of that help us estimate his likelihood of resistance a little bit more? Unfortunately, couldn't find a lot of good studies. Certainly, we just talked about that HIV acquisition prior to PrEP is obviously a big risk factor. Some of these PrEP studies did involve tenofovir monotherapy, which seemed to have a slight increased risk of resistance acquisition. And then, of course, there's that kind of Goldilocks level of having enough adherence where you can, to your PrEP, where you do acquire resistance, but not so much that you are avoiding HIV. But unfortunately, I couldn't find anything that would give us greater precision. I even did look into some to see if there were any old trials back from the 90s of just tenofovir and 3TC alone for HIV treatment, dual NRTI therapy, to look at resistance rates, but could not find anything, at least for those particular ones. What about the genotype? So a genotype for somebody who last took their oral PrEP maybe about 3 or 4 months ago, how likely are we to be able to trust those results, or at least trust them in the sense that, are we going to see resistance if he has it? So what we have here is there is a study that looked at 9 patients who seroconverted in the Partners PrEP study and were found to have resistance and did not start ART right away in that study. So among those patients, all of their genotypes 1 month after stopping their oral PrEP continued to show the resistance mutations. Unfortunately, the next time point they presented was 6 months out, and they had, at that point, had lost those resistance mutations. So what happens for 3 or 4 months for our patient, I'm not sure, but it would make me at least concerned that we're missing resistance if this patient has wild type virus. So what we're going to do in this case, I was going to say we're going to peer into our crystal ball, but this is more of a scientific case. So we're going to travel into the future, which Einstein's general theory of relativity says is possible. As long as we travel close to the speed of light, we can, away from monogram sciences, we can get his genotype results quite quickly. We will, of course, bring the patient with us so that there is no risk of ongoing transmission of HIV. And if we travel into the future a couple weeks, let's say we get a theoretical genotype result as such. We have NRTI resistance mutations of K65R and M184V, nothing else. So now we have tenofovir and FTC resistance, which we're at least concerned about. And in this theoretical case, at least right now, what will we do? So let's go back to our regimens. This is just an opportunity also for me to poll the audience. I'm curious what you would do in this scenario. So now we have somebody whom we actually, same scenario, eager to start treatment, but we have known or documented tenofovir and 3TC resistance. I'm curious to see how these results do or don't change from the prior question. He is motivated. He would take injectables. He is motivated to start treatment, definitely wants to start treatment. Things are going pretty well on the other pills that he's been taking the last couple of months, but hasn't expressed a strong preference between the two. Great point. I won't call on you if you pick something else either. So. All right, so now we have, we got a couple something else. Perfect. Yeah, so now we have a couple of people thinking about long-acting cabrylpivirine, and then I'd say, yeah, a few more results for boosted darunavir with dolutegravir, and then and BIC has fallen off here. Okay, very interesting. So those of you who have spent time with me in clinic have heard me talk ad nauseum about the Nadia and DEF trials. So what I'm going to do here is talk ad nauseum about the Nadia and DEF trials. Now, I am going to talk a little bit about them, though. I know these are trials that you all are quite familiar with, but I did want to highlight one point before we get into kind of the main course of our treatment. So as a reminder, Nadia is I think both of these trials at least can inform how we think about, through extrapolation, how we think about the setting. So these are patients who have failed first-line therapy with NRTIs, so not totally analogous to our patient situation, but many of them have baseline NRTI resistance, which is analogous to this situation. And in this trial, 2x2 design looking at dolutegravir versus darunavir, but also a second arm looking at AZT versus tenofovir, trying to kind of put to rest the debate about the World Health Organization guidelines at the time around switching NRTI therapy at the time of failure. So two different comparisons, the partner drug and AZT versus tenofovir. So just really quickly, as kind of a reminder, using their primary outcome of viral load cutoff of 400, the tenofovir to AZT comparison, tenofovir was superior to AZT, did not reach significance for viral load of 50, but did for 400. And if we look at the subgroups, for patients who had intermediate or high level tenofovir resistance, like this patient in this scenario, there was still no difference. So 94% response rate for those who got tenofovir despite resistance versus 91.6 for those who got AZT. If we look at the dolutegravir versus darunavir comparison, this was non-inferior using the viral load cutoff of 50 or 400 in this comparison. But the big, as we say, not all failures created equally. Among the patients who did fail dolutegravir, we did see dolutegravir resistance emerging in 7 patients and none in darunavir. So the last thing that I think is interesting in terms of thinking about these options, of course, is if both NRTIs are inactive, this group right here, patients still did really well, right? 91% response for dolutegravir, 92.5 for darunavir, despite no active NRTIs. Now, I will say these are the this is the subgroup of patients who are more adherent to therapy, because everybody's failing in this trial. And so if you're failing with no active NRTIs, that's because you are taking your medications. So I think in the subgroup of patients who are more adherent to inactive NRTIs with one of these partner drugs, we see rates of response a little north of 90%, which is great. But the dolutegravir kind of goes down in flames more often than darunavir in terms of developing resistance. So TDF superior to AZT, dolutegravir non-inferior to darunavir, but no emergent darunavir mutations. So kind of the question is this the better option than among patients who may have adherence challenges? I think that the Nadia results kind of suggest that. Then we get DEFT. And so DEFT, just look at kind of the stage 2, I think, for simplicity and expedience. Similar patient population in an RTI failure. We have these similar 2 groups, but now we have darunavir with dolutegravir, which many of you wanted to do, and no NRTIs. And then we have TLD and a standard of care, kind of 2 NRTIs with boosted darunavir arm. And so what's interesting about this and what's different, and what I wanted to highlight really with talking about these trials, is we now see an inferiority of darunavir with 2 NRTIs. So before, that was compared to dolu with 2 NRTIs, those results were non-inferior, and now we see inferiority with that regimen. And so same thing with resistance, none with darunavir, very little with dolutegravir, but it was there. People did fail dolutegravir with resistance. So kind of DEFT after Nadia, reinforced the viability of tenofovir FTC with dolutegravir after failure, even if both NRTIs are active, but with some caveats. It did reinforce this higher barrier to resistance to darunavir, which is why I think many of you are thinking about darunavir in this trial or in this setting. And it added this 2-drug NRTI sparing regimen as a good option. So how do we reconcile the non-inferiority of dolutegravir to boosted darunavir when paired with 2 NRTIs that we saw in Nadia, with the superiority of dolutegravir to darunavir with 2 NRTIs in DEFT? And I think the way we reconcile it is actually the difference in NRTIs in this trial. So that's, I think, the main point that I wanted to highlight is everybody in the dolutegravir and 2 NRTI trial or arm got tenofovir, whereas the World Health Organization standard of care at the time of NRTI switching was applied in the darunavir group. And so what happened is if people were failing tenofovir, they were switched to AZT, or if they were failing AZT, they were switched to tenofovir, or some of the study sites in this trial had resistance testing, and so they were changed based on their resistance testing if the study site used it. And what ended up happening is AZT was used in about 77% of these patients in the darunavir arm in this trial. And so what that means is these patients, we know from Nadia that AZT was actually inferior, at least at a viral load of 400, to tenofovir. And so what we know is, in a way, the darunavir arm in DEFT is kind of fighting with one hand behind its back because it's using AZT, which was inferior in Nadia. And so I think that is, potentially, unfortunately, in their supplemental material in the study itself, they didn't break down the virologic responses between those who got AZT and tenofovir and darunavir in DEFT, but I think may explain some of the options or some of the differences here in these trials. So I think TAF, FTC, darunavir, cobicistat still a very good option, especially if people want single tablet regimens, despite this possible inferiority in DEFT. So kind of getting back to these, I think, bictegravir requires some extrapolation from the dolutegravir data, but if an STR is really desired, then great. You could potentially kind of wander off of the evidence base and do that. Tenofovir, FTC, dolutegravir, I think is a good option. I view this as kind of the Taylor Swift blank space option, and that it could be forever, it could last forever, but it could go down in flames, and you could develop dolutegravir resistance. That's why Tay-Tay's on my slide here. The boosted darunavir, or Simtusa option, I think is a great option if the PI is reasonable, especially if somebody wants a single tablet regimen. And then maybe the best option, and that seems to be most prevalent in our poll, would just be skip the NRTIs entirely and just go to boosted darunavir and dolu. And then cabrylpivirine, I think, is an option. It's not crazy, especially if a patient may really have adherence challenges. So let's get to the main course of this. So like we try to do in our clinic, this is where things kind of quickly became a dumpster fire. We looked at the patient's med list and we're like, oh, what's this patient taking? So this is his med list. And he is taking oxcarbazepine for his seizures. And he has been taking this for the last 4 weeks because he reestablished in primary care and an epilepsy clinic. And I thought this was a medication that only existed like on the IAS, like multiple choice questions, or maybe the ID boards, but it actually exists in real life and our patient was taking it. This is a notorious drug-drug interaction challenge. And so it's an inducer of many enzymes that are responsible for ART metabolism, an inhibitor also of one of the CYP enzymes. And if you look at the DHHS and University of Liverpool guidelines, this is kind of what they say for a lot of the ART that we use or may use. So the only thing that's in green is the thing that we're worried he is resistant to, the two NRTIs. And everything else at least has a caution, or the US guidelines sometimes say contraindicated and sometimes avoid. I'm not totally sure what both of those, what the difference is between those two, but both of them are quite concerning. So now we have, let's call it a situation. We have a situation here, and I think there are a lot of challenges for what to do. So I'm not going to go through and read all of this, but there's mention about substantial TAF decrease in levels, although that's extrapolated from rifampin because there weren't many TAF studies with carbamazepine or oxcarbazepine. Etravirine, they said, had not been studied, but you don't have to dose adjust. You could just monitor closely with caution. Atazanavir levels dropped quite a bit. Boosted darunavir is listed as a use with caution, but they did say that therapeutic drug monitoring results were pretty comparable. And so I was like, oh, that's interesting. And then there were issues around, TAF FTC BIC. So UGT1A1, not to be confused with A1A, Beachfront Avenue, of course, Vanilla Ice reference for all you fans, is induced, and so therefore recommendation to avoid BIC. And the dolutegravir data is concerning the trough concentrations were down by 83% in patients who were on oxcarbazepine. And then RAL, the data just kind of says, well, it could potentially be decreased, but we don't have good evidence. So we're trying to find a way to get around these things with this patient. So most of these reports through Liverpool and DHS do cite one study, which I wanted to get into. So it's this clinic in Milan, Italy called the GAP Clinic, which partners with HIV providers and clinics via referrals. You have to refer your patients there. To reduce polypharmacy and minimize either known or kind of suspected harmful drug-drug interactions. And they perform a lot of therapeutic drug monitoring. So if you dive down into the references for some of these sites like Liverpool, many times the papers are coming out of here. And they do this on patients who are on complex or kind of poorly studied regimens. So they have this study where they looked at their database of 900 patients. These are probably not your average HIV patients, but patients who were referred to them because they were on complex regimens or many different medications. And they tried to identify anyone who was on oxcarbazepine or carbamazepine for at least 3 months and non-recommended ART or ART that might be problematic, which is basically every agent. And those patients in their database, many of them had therapeutic drug monitoring, and they compared those results to all the other patients in their database who had therapeutic drug monitoring but were not on these agents. Now, what we don't know is, were they on other agents that were concerning? What was their renal function like? They're probably not your average HIV population. But they found 7 patients that were on carbamazepine and 4 that were on oxcarbazepine, and they performed therapeutic drug monitoring 57 times on 8 different ARVs. And they also looked at, are the ARVs affecting the anti-epileptic drug levels? The short answer is probably not significantly, so we don't have to at least worry about an interaction in that direction. And they reported their results against 1,200 patients who had other reasons for therapeutic drug monitoring. So how do we do? So this is kind of a summary, and this is where a lot of the Liverpool data comes from. They looked at their controls, their trough concentrations compared to the subjects on the anti-epileptic drugs. They reported the percent change. And then they also highlighted, which I think is somewhat, I have some caveats around this, what they found in the literature or in their own studies of what the minimum therapeutic trough is for these medications. Unfortunately, the paper they cited for getting the minimum therapeutic trough was actually their own paper, which kind of didn't delve into the specifics around each minimum therapeutic trough. But this is where we get the dolutegravir reduction in 83% and a lot of other trough level reductions here. So they didn't have enough samples for albuterol and rilpivirine, so they didn't include them. So kind of the takeaways at this stage, looking at this paper on the reductions is, our 3TC or FTC should be fine, although we may have resistance mutations. Again, that travel into the future thing was theoretical. And tenofovir, TDF is likely a safe bet. It gets a green box for the guidelines-based recommendations, unless they're resistance mutations. So kind of one question we had was, would TAF be okay if we use the TAF FTC dosing, which is 25 milligrams, and then paired it with a booster to try and get its levels even higher? So TAF, when it's part of Simtuza, are already paired with a booster is 10 milligrams, whereas TAF FTC is 25. So it has a pretty big therapeutic window. So we could give the 25 with the booster and maybe get higher levels. Although we're really kind of wandering away from the evidence base. The other takeaway is boosted darunavir looked pretty good. So going back to that prior table, the levels were pretty similar and well above the therapeutic target. But, we're making decisions with very few patients. They didn't specify a breakdown between carbamazepine and oxcarbazepine. And we suspect they're very similar, but we don't know. And they also didn't really specify a difference between ritonavir or Kobe. Do we push the dose? Do we give 600/100? Something we could do. Is that safer or is that too much? And then the question is, do we want to hang our hat on 2 NRTIs and boosted darunavir, or do we want to add something else? And if so, what? So etravirine gets a caution, but says no dose adjustment. We could use that. Is it embarrassing to use etravirine in this day and age? I'm not sure, but that at least crossed my mind. Raltegravir gets caution in the US and European guidelines. You can't do the HD daily dosing. The levels are really unpredictable. If we go back here, they had this huge range, and they didn't actually describe how their plus minuses were calculated. So I'm not sure what a mean of 849 plus minus 1184 means. Like, did people have negative raltegravir levels? But they kind of felt like there was such a variation that it was hard to make conclusions. Or do we do dolutegravir? And there's this discrepancy. So you may recall Liverpool says, and the European guideline says you could do dolutegravir twice a day. The US says avoid. And what are the optics of like starting a medication where there's this 83% reduction in trough level? So I'm curious, let's think about our optimal regimen, knowing this. And we're just going to start, there are too many permutations. We're just going to start with the NRTIs first, and then we'll talk about the partner drugs. So what would you kind of do knowing what we know now with our NRTIs? Would we do TDF FTC? Would we do TAF at standard dosing with FTC? Would we do TAF 25 and try and pair it with a pharmacologic booster like a Kobe or ritonavir to bring up those levels? Would we do something else? Would we not use any NRTIs as part of our regimen? And we don't know his T cells, unfortunately. We don't know his viral load either, actually. Or would we talk to neuro as soon as possible, try and get him off oxcarbazepine, just defer ART for a couple of weeks and go from there? Okay. All right. Yeah. Oh, wow. What a great spread. Good. So these are all things that we considered. And we did actually, he was very motivated to start therapy. We did also, float this last idea, although it made us all uncomfortable not starting therapy. And for a couple of weeks, and he really wanted to start therapy, and and we felt like that was the best thing to do, but definitely something that we considered, and seems to be the plurality at this point. But we see a couple of votes for TAF at different dosing. Great. And then what about the partner drug now? So think about that optimal regimen. What would you want to do? Would you hang your hat on boosted darunavir here? And I'm not saying there's a right answer to this. This is, again, like an opinion poll in a way. Would you do twice a day dolutegravir like the Europeans? They've got universal healthcare there. Maybe they know what they're doing. Would you do both? Would you actually stick to the sort of, caution and not contraindicated raltegravir? Would you survive the embarrassment and do etravirine with boosted darunavir? Would you do another partner drug combination? Or are you sticking to your guns and saying, let's get them off the oxcarbazepine? All right. So we got a lot of folks. All right. A little over half wanting to do boosted darunavir with dolutegravir. Some of you may have wanted to pair that with certain NRTIs as well. So great. Love it. But a good spread of what to do here. So kind of this question came up of like, this difference in dolutegravir dosing and like, how can the Europeans, recommend this, a twice a day dolutegravir when we at least know once a day dolutegravir leads to an 83% reduction with these anti-epileptic drugs. So kind of I'm going to bring you down the rabbit hole that we eventually headed down. And this is spring one. And this is so spring two is dolu versus raltegravir. This is spring one. This is one of the dose finding trials among adults. So these are ART naive individuals with HIV, and they were randomized to 3 different doses of dolutegravir: 10 milligrams, 25 milligrams, and 50 milligrams, the dose we use now, versus efavirenz, paired with 2 NRTIs at the time of initiation. And they had a number of patients who had high viral loads, greater than 100,000, and their median CD4 count was 324. So how did they do on these 3 different doses? We all know that we settled on 50 milligrams once a day. They actually did really well on dolutegravir 10 milligrams. So the rate of suppression was equivalent, actually numerically slightly higher on dolu 10 milligrams compared to dolu 25 and dolu 50. It was well tolerated. The AEs were very similar between these groups. And so eventually, kind of based on this, they're like, oh, it's well tolerated at all these doses. This and other studies led to 50 milligrams moving forward. But you actually saw excellent virologic responses at 10 milligrams of dolutegravir, and no dolutegravir resistance emerged in this trial, though 1 patient had M1A4B on 10 milligrams. It's a little different when you go out to 96 weeks. They actually had a drop off in the 10 milligram arm, not because of new resistance, but because a couple patients who had viral rebound in this trial. But all of these groups were superior to efavirenz and no new resistance mutations. So I was kind of shocked to find out, like, wow, if my patients use a pill cutter and cut their dolutegravir into fifths and take that every day, they're probably going to do okay, at least according to spring one. So interestingly, the mean trough concentration was 300 milligrams in this trial, the subset who had this studied on dolu 10 milligrams. So how does that compare? Getting back to the trough concentrations we saw in this study of, again, just 7 patients, their mean trough concentrations were 191. So unfortunately, still below that kind of safety of a trough concentration potentially of 300 in the 10 milligram arm. Now, could we get above that safety of 3? Is 300 the minimum? 300 seems safe based on spring one, but could we go even lower? Potentially, but we really don't have data. Could we get above 300 with Q12 dosing instead of daily dosing? Maybe, but that could be, it's not a linear thing. That could be irresponsible math. So last question before I turn it over to Anne and tell you what happens with this patient. How does this influence your opinion of dolutegravir for this patient? I already wanted it. I feel better. I already wanted it, but I don't like it. I didn't want it and I still don't. Or can we just please find an ID pharmacist who's going to tell us what to do, which is one thing that I did. Yeah, I like the D. Great. Yeah, so I will say we did not go as far down the rabbit hole on that first day as I have done now. But I definitely discussed this with a couple of ID pharmacists that first day. We didn't come up with a regimen while the patient was still in clinic. And so this is what happened. Although now that I've gone farther down the rabbit hole, I think I would fall into this category of feeling a little better about the dolutegravir data, at least at Q12. So he was amenable to a complex regimen over a short period of time. He really wanted to start therapy. We actually, in the moment, although I think I would go with dolutegravir Q12 now, stuck with the sort of caution and not contraindicated approach to INSTIs and did Q12 raltegravir again, which is not what I would do now with TDF-FTC and daily boosted darunavir. Changed his nasal steroids to beclomethasone. His HIV result finally came back at 5,800. That was his viral load. His genotyping was notable for just an RT mutation, although maybe he was harboring something else. And he had high self-reported adherence, no tolerability concerns 7 days after start, and he became undetectable after about 3.5 weeks when we got his next viral load. Eventually, we changed him to taf-FTC-BIC as he came off the oxcarbazepine. And he did have a little blip and then moved to Los Angeles. So he's only in our clinic for about 6 months or so, but became undetectable. He did stop his topiramate, which was his new epilepsy drug. But I think at least going farther down the rabbit hole after that first day, I would probably go with, I think a Q12 dolutegravir is probably a better option in this scenario than Q12 raltegravir, but I think both are reasonable. That's it. So thank you for bearing with me and appreciate the time. I'm going to turn it back over to Anne.
All right, just a quick reminder to claim your CME credits. Okay, so we're gonna move right along. I'm gonna do 2 shorter cases today. So we'll start with a different inpatient or outpatient case. So this is a gentleman I was meeting on my panel this year. He's 73 years old. He has a past history of neurosyphilis, which was complicated by a CVA a long time ago, has residual right-sided deficits because of it, neuropathy, longstanding use of a wheelchair, and some cardiac comorbidities, who is seen in clinic with longstanding well-controlled HIV. So let's go through his treatment history a bit. So he was diagnosed in 1991. His treatment history, he initially started on AZT monotherapy, which he continued for about 5 years or so. Eventually 3TC was added to his regimen. He also went through a series of other regimens and kind of random pill switches in the 90s and early 2000s that he doesn't entirely remember. Based on chart and his recollection from a nice like pill diagram in clinic, he recalls nelfinavir, lopinavir, ritonavir, and says, you know, there must have been some others that I was on. Our records sort of document his first complete regimen with sequinavir, D4T, and efavirenz until 2003. And of note, oh, this color changed a little bit, but he was viremic during this entire time. And then, oh, it doesn't align quite right. Okay, so he switches to amprenavir with DDI and tenofovir, and that's his first regimen that he suppressed on in 2003. So this earlier in the 90s was viremic throughout this time. His PI is changed to fosamprenavir a little bit later in his course, and then once raltegravir is available, the DDI is switched to raltegravir, and he continues on tenofovir, suppressed throughout all of this, and then continues along the rest of his history maintaining suppression. Eventually, his PI is updated to darunavir ritonavir. He remains on his INSTI and tenofovir, which he's eventually switched off TDF because of nephrotoxicity. Darunavir is updated to boosted with COVID, and then dolutegravir is also updated. And then sort of during this time, they wanted to lower the number of pills he was taking, so he switched to boosted darunavir with the dolu rilpivirine single tablet regimen. And then in this late 20-teens, early 2020, a lot of things happen with him. His neuropathy progresses, his CVA residual defects and his like lumbar spine issues just become kind of overwhelming, and he has a lot of issues with mobility, so he starts using a wheelchair full time. It's also kind of coincides with the COVID pandemic. He's not getting out as much. He's a little bit less physically active. So a lot has changed in his lifestyle, and he gains about 60 pounds over 3 to 4 years there. At that time, there's concern from his provider that this is probably mostly related to changes in his lifestyle. However, there's emerging data about integrase, second generation integrases causing weight gain, particularly along with TAF. And so a decision is made to switch him to off the INSTI to darunavir COVID with doravirine, which he has been on since 2021 and maintains virologic suppression, satisfied with this regimen. For his resistance data, we have one genotype that was done in the 2000 range. This is when he was on a failing regimen. He had an A62V for NRTI mutations and an L210W. For NNRTI, he just has a K103N, and then he doesn't have any darunavir RAMs, but does have a lot of RAMs from older PIs. So this is corresponding to his earlier treatment history there in the 2000s. But of note, he's failed a lot of the early NRTIs, including 3TC, so wondering if we're missing some mutations there as well. Okay, moving on to the rest of his data, he's core antibody and surface antibody positive with a really high surface antibody titer. His GFR is normal. His lipids are well controlled on a statin. He's on a atorvastatin and aspirin for his history of stroke and dyslipidemia. He has losartan for his hypertension, and then is on pregabalin and trazodone. So we're thinking about this gentleman, and kind of what we might do to change his regimen. Maybe we would change it, maybe we won't. So a few options here. We can just continue the boosted dronabinol and doravirine that he's on. His lipids are well controlled. We're not too worried about that. He's satisfied. He's able to take it. It's fine. We could potentially continue or switch him to BIC-TAF FTC. Maybe he wants a single tablet regimen. We'll reduce kind of his overall pill burden. Maybe you're thinking about reducing polypharmacy overall, might switch to Dolu-3TC. And then mostly I wanted to talk today about sort of our new drugs that are in the pipeline. Would we wait for BIC-LEN for this guy, or maybe doravirine islatravir? So hopefully y'all have had a minute to enter what you're thinking. Great, we have a pretty good split here. Okay, so a lot of folks are thinking, why fix what isn't broken? He's doing fine on boosted darunavir. He doesn't have any real problematic DDI, so we can do that. Some people want to put him on a single tablet regimen, which is also fair. No one's going for the Dolu-3TC, and a couple people are waiting for novel regimens. Awesome. Oops. Okay, looks like my colors got reversed again. A and B, I think, are totally fine. We could continue what he's on. We could switch him to a single tablet regimen. I agree with the audience that we're not going to switch him to Dolu-3TC because his history is far too concerning for an M184V that maybe didn't show up in our genotype. And then I think BIC-LEN actually might be a really nice choice for this gentleman. And I'll go through why I don't think doravirine islatravir will be a great option for him. So at CROI this year, we learned a little bit more about doravirine islatravir and kind of what's the latest with these clinical trials that are ongoing. So on the left-hand side, we're looking at the Lancet article that was just published for initial treatment with doravirine islatravir for folks who are naive to therapy, which I thought was particularly exciting because often with these new combinations, we don't get treatment naive studies right out the gate. And so thinking a little bit about who could potentially qualify for this treatment. Of course, they excluded doravirine mutations, but looking at the NRTI excluded mutations, they were pretty restrictive. So couldn't have a K65R, couldn't have an M184V, couldn't have certain TAMs, or not at least 3 TAMs or more. So we really don't want any compromise in the NRTI backbone to use this combination, at least in the clinical trial. And then looking a little bit more about the 2 failures that were published in this group. So in the bottom left here, we see the 2 folks who failed with resistance on doravirine islatravir. And those 2 folks notably had pretty high HIV RNAs at the start. They were in the millions range when they were initiated on treatment. They didn't really have any major doravirine or NRTI RAMs at initiation, but looking at their treatment emergent RAMs, I mean, they both fail with pretty significant doravirine associated mutations. The first one fails with a Y188L, and the second one picks up a V106A and an F227L, both of those resulting in phenotypic reduction pretty dramatically of doravirine resistance. And then interestingly, this also comes along with an M184 substitution. But this retains islatravir susceptibility. So the fold change increases a bit, so maybe not quite as susceptible to islatravir as initially, but certainly the M184 is emerging as sort of a signature mutation for failure on an islatravir-based regimen. And this is supported in some of the in vitro studies earlier prior to islatravir in the clinical trial. So some signal here that M184V is not ideal with islatravir. And then on the right-hand side, I looked at the 2 posters that were presented at CROI this year. So these were the switch studies. One is a switch study for people who are just on standard of care ART, switching to doravirine islatravir. They had to be virologically suppressed. And the other is folks who are on BIC-TAF FTC and were switched when suppressed. And then interestingly, who was excluded from these trials? Anyone with prior treatment failure. So our patient would not meet criteria for entry in this study. And then doravirine rams, but they didn't necessarily specify NRTI mutations that had to be excluded. Of these two studies, there was one failure with resistance reported that developed doravirine resistance and then retained islatravir susceptibility, but with a 7.4-fold decrease in susceptibility, still technically susceptible. And then notably, this person had a M184V in their archive genotype. Not clear, if this is a replication competent virus or not, but certainly it gives a bit more signal that an M184 is predisposing to islatravir failure. So based on all of this, I think doravirine islatravir alone is not really ready for our heavily treatment experienced population who certainly has picked up some NRTI mutations in the early 90s. So I wouldn't use this for a gentleman. Perhaps in the future, as part of a combination therapy, it could be useful, but not for him so far. And then looking at BIC-LEN, so we recently got the results of the Artistry-1 phase 3 trial, which was very exciting, I think, because we looked at suppressed adults who were on complex ART regimens, which are often not included in these initial trials of new drugs. So these adults had to be virologically suppressed for at least 6 months, and they had to be doing well on complex ARB regimens. They were on an average of, or a median of 3 drugs as part of their complex ART, and they had to be taking at least 2 tablets per day. And as one would imagine, these were pretty diverse regimens in a heavily treatment experienced population. So the two kind of most common regimens that folks were on were PI and INSTI-based regimens, plus or minus NRTI or NNRTI as an additional supportive agent, but a lot of diversity there. These folks had a median duration of treatment of 28 years, so very heavily treatment experienced and had failed prior regimens. And then looking at their baseline resistance, almost everyone had resistance in their NRTI or NNRTI mutations, a lot of PI resistance as well, and notably almost no INSTI resistance. And I think this is kind of reflective of the patient population who's been treated since the 90s, who probably picked up a lot of these mutations early on, but remained pretty treatment adherent as their ART evolved and didn't necessarily pick up integrase mutations. Also, I think importantly, this population had a lot of comorbidities, so hypertension, hyperlipidemia, diabetes, and then CKD. They allowed folks in the trial that had a GFR above 15, which I think is always helpful to get more data about folks with advanced CKD, although there's only 1 or 2 patients that actually had a GFR in the 15 to 30 range. And notably, they excluded folks with decompensated cirrhosis, so no more data for that patient population. And these folks were randomized to BIC-LEN as a single tablet regimen once daily, or they could continue their complicated ART that they were already on and doing fine. And the outcome of this trial demonstrated non-inferiority for the BIC-LEN single tablet regimen. But notably, the main benefit was that patients were a lot more satisfied with their single tablet regimen. So much higher patient satisfaction and equally efficacious. There were 2 patients in the BIC-LEN group that had a viral load above 200, but they didn't develop any treatment emergent RAMs. They didn't publish on if, those people were resuppressed on BIC-LEN or changed their regimen. But overall, for complex treatment history, folks are doing very well on BIC and LEN. And then I think, as we've used LEN more for long-acting injectables, I think kind of the crux of this drug is going to be the drug-drug interactions. And we're still learning more about what this actually looks like in the real world. Helpfully, this study excluded only a small list of drugs. So dofetilide, which can't be used with bictegravir, sort of the bad anti-epileptic drugs that David was talking about earlier. Unfortunately, but unsurprisingly, the rifamycins are also excluded. So they really allowed a lot of variety of drugs in, but unfortunately didn't publish all the details of like every drug combination or anything more than just like it was very common that folks were on lipid lowering agents, anti-diabetic agents, and antihypertensive agents. So you can kind of guess some of the main drugs, but I think there still are a lot of questions about how do things play out in real life with lenacapavir, with a long list of drugs on Liverpool and DHHS that just say monitor and use with caution. I think one of the main benefits that we also saw in this trial as a secondary outcome were the improvements in lipid profiles. So folks who were switched to Bic/Len rather than on their complex regimen had significant reductions in their triglycerides, their total cholesterol, and their LDL cholesterol, which can be very helpful in this aging patient population. Of note, it's felt that most of the improvements in lipid profile were driven by the loss of the boosted PI rather than some like intrinsic benefit of Bic and Len. But just sort of goes to show that there is some room for improvement in the side effect profile of some of these complex regimens. So in summary for this case, my takeaway is that I think I'm going to avoid doravirine islatravir with in folks with M184Vs or pretty significant treatment failure from the early 90s or NRTI failure in the past. But I think that Bic/Len is actually a pretty promising way to reduce polypharmacy in some of our long-term survivors and avoid a lot of these adverse effects of the complex regimens that tend to accumulate over time. And then we really need more real world data about what's happening with a lot of the Len-related DDI. A lot of what's extrapolated now is based on other drugs and moderate CYP inhibition. So I don't think we know how Len plays out with things such as like anticoagulants, where you have a little bit less room for error. So hopefully we'll get more real world data as this is rolled out further. So in this case, I've currently left the patient on boosted darunavir and doravirine, and then I think I'll talk to him about Len/Bic in the future. Okay, so we'll do our second case, and this is going to be switching gears a little bit. We'll move into the inpatient world. So this is a gentleman who was admitted at Parnassus a couple months ago. He's a 54-year-old guy. He has a history of VTE and a periodontal abscess. He's got advanced HIV, and he's been off ARVs for over a year. And he's coming in with 10 days of fever, cough, and fatigue. So we'll move through his initial presentation pretty quickly, but he's tachycardic and febrile on presentation. His vital signs or his labs are notable for a normal white count, a bit of an AKI and hyponatremia, and then transaminitis. In his CT chest, he has a left lower lobe mass-like consolidation with a central cavity. And for his social history, he's local. He hasn't really traveled out of the United States or to other states. He sleeps in a car, but not in congregate living facilities or a shelter. And he doesn't use any drugs or have any animal exposure. And then here's a couple representative sections of his CT chest. So on the left side, you can see kind of the lower slice of the mass-like consolidation here, which is opening up into a cavity that we see here, some other scattered nodules and GGOs. So he started on broad spectrum antibiotics. Of course, we send a serologic workup and sputum studies, and his CRAG returns positive at less than 1 to 5. He started on ampho and flucytosine for concern for disseminated cryptococcal infection, and then worked up for CNS involvement of crypto. His MRI brain just shows chronic microvascular ischemic changes, no mass lesions or leptomeningeal enhancement. And then he has an LP done with a normal opening pressure, mild lymphocytic pleocytosis, a normal glucose and protein. The cultures are pending. The CRAG from his CSF is negative, and the NGS on the CSF just shows HIV. He's not making sputa, so we move forward with getting a bronch. And then next question quickly, what's your leading differential diagnosis for his cavitary pneumonia? Do you think this is a typical CAP process? TB, of course. Is this a cryptococcal pulmonary infection as well as disseminated crypto? An endemic mycosis, PCP, or something else? A lot of votes for endemic mycosis, which certainly could be the case. Some atypical bacteria. Oops, dang. Okay, sorry, that went away. A little bit of crypto, and then surprisingly, Legionella grows on his Legionella culture, which was, I don't think, what anyone expected. So in this case, I wanted to talk a little bit about Legionella and HIV because this is not something that we see very often. And actually, in review of the literature, it's very uncommonly reported even in advanced HIV. So there are some scant case series out there from the 90s and early 2000s, but mostly very small numbers of patients. Some of these suggest that there's worse disease in HIV. Others show kind of equivocal and not worsening even with AIDS. Most of these case series are hospital-acquired infections. And then of note, Legionella is seen much more commonly with other forms of immunosuppression, particularly TNF-alpha inhibitors, steroids, and the transplant patient population. So why is that? I think a lot of this has to do with the immune response to Legionella. So Legionella is an intracellular pathogen that is phagocytosed by macrophages in the alveolus, and much of the initial control of Legionella is actually directed by the innate immune system. So activation of neutrophils, as well as antigen-presenting cells. And then much control is related to kind of the cytokine signaling cascades and anti-inflammatory pathways that these cells take us down. Of note, a lot of involvement of TNF-alpha, interferon gamma, and associated cytokines, suggesting kind of why some of those forms of immunosuppression result in more severe Legionella disease. And then T cells are certainly involved, but it's felt that CD8 T cells play a larger role than CD4 T cells. So perhaps much of this variation or much of this immune control is not as impacted by advanced HIV, despite us thinking of those patients as quite vulnerable to many infections. And then management of Legionella. So we often use levofloxacin or azithromycin, but where does this data really come from? So a long time ago, levofloxacin was compared both in vitro and in vivo to chlorithro and erythro, so our older macrolides, and was definitely demonstrated better efficacy. But in vitro, we have data that azithromycin is equivalent and comparable to levofloxacin, but unfortunately no comparable clinical trial data comparing levofloxacin to azithromycin in clinical patients. So essentially you can choose either, and they're both appropriate based on tolerance or patient comorbidities. So what happened with our case? So he was recommended a 21-day course of azithromycin, a longer course for his underlying immunosuppression. His crypto infection was deemed to be more asymptomatic antigenemia and was treated with fluconazole. He was discharged to med respite, but then unfortunately promptly lost to follow-up. But 6 weeks later, he shows up in another ED where they repeat a CT chest, and the left lower lobe lesion is markedly improved and essentially gone. And then recently has represented to his HIV clinic and is doing well from a respiratory standpoint and started back on ARBs. So how long should we really be treating Legionella? The optimal duration is not clearly defined. Much of it is defined by patient's clinical response. For mild disease, only 5 to 7 days is sufficient, but for immunocompromised patients in our transplant population, we're usually treating for 14 to 21 days. And in his case, we thought, larger cavitary lesion plus low CD4 would be an indication that he would need longer treatment. However, he clinically resolved despite a shorter course of only 7 to 10 days of therapy. And I think likely a lot of this had to do with his low CD4s being less impactful than other forms of immunosuppression. So summary for this case, the host response to Legionella is less dependent overall on CD4 T cells, making it a very uncommon OI. Outcomes are not clearly worse in people with HIV, even when they have advanced HIV. And other forms of immunosuppression place patients more at risk, including TNF-alpha inhibitors, steroids, and transplant patients. Okay, we can take questions now.
Great. Any questions? Annie, curious what you think about the M184V and islatravir. Yeah.
Other people go, but you called me out. So thanks. And that was, two comments about the treatment naive. It was also interesting when people failed, it was really high viral loads. So they were at 1 million and 2 million. So maybe that's a lesion here. I think we need to learn more. One thing in one of your slides, so M184B is not a doravirine. It doesn't affect doravirine. It affects islatravir. And then there's this whole question about, well, it may be treatment emergent, but the Merck's data suggests that it's a 20-fold to have lack of susceptibility. We never love seeing something emerge and there was a decrease in susceptibility. So I don't know. I think we're learning more here, but I share your thoughts about, wanting more data about what this looks like in people with known M184B. I'll just make one other comment about that treatment naive study, which is really interesting. They excluded M184B not because of islatravir. They excluded it because of Biktarvy before the labeling had changed to say that it was okay. So I actually do have a new study that's enrolling for treatment naives with ulonivirine, which is related to doravirine, where they don't exclude M184B. So there will be more data to help inform us here. But I had understood, oh, well, gosh, if you didn't want people in if they had an M184B, but they made it really clear that was not because of islatravir. So I think we're all learning here.
And did Island exclude M184B? Can you remind me? That's the islatravir len once.
That's a great. I don't know off the top of my head, but I can look it up. Crowdsourcing. Does anyone know off the top of their heads? I don't know. Did Island exclude M184B? It did not. Okay.
Thank you.
Good to know. And then I'll just make one comment about Legionella, which I'm glad that you brought that up. There was just a really good review, I think in CID, a bunch of hospitalized super sick cases showing that only 25% of people were positive by the urine antigen. And so just a reminder, like, I'm so glad this person was able to be diagnosed, but that our index of suspicion needs to be high, both with and without HIV. And I think we probably miss Legionella a lot more than we realize. And this is where we have to tell the lab, yes, we really did want that, get it in the blood. We do want to get a culture. We do want to push for the PCR. So, which is sometimes harder here than at other campuses.
Great. Does anyone have a quick question since we're already over? No, not in the chat. Okay. Well, thanks so much for visiting us. We had 65 people on Zoom, so well attended. Thanks so much.